Is this look right to everybody?
Looks great.
Okay. So my talk, the diagnosis and management of osteoporosis and CKD. Everything I'm going to say today is now up and expanded on online in a review article that I've written along with my mentor Joe Ix in the most recent edition of American Journal of Kidney Disease. So if you have questions, I'm available, but obviously it's all on paper. Some objectives, you can see them here: discuss the burden of osteoporosis, how we work it up, how we treat it, and why what we're doing really historically hasn't been working. So, most of you guys probably know this already, but the burden of osteoporosis and CKD is extremely high. According to some NHANES data, to some WHO data, almost a quarter of the women in this country with a diagnosis of osteoporosis have a low EGFR. Fracture risks are higher in CKD, they're much higher in ESRD. And the problem that you've all talked about already and that we run into is when you get into stage 3B, 4, and certainly ESRD, there are essentially no large trials to guide therapy. What you have is very small trials, or you have trials that excluded these patients, but essentially had some by accident or just coincidentally, and you do subgroup analyses of those. The only exception I'll say to that is I believe Madhu Rao is on this call, and at Kentucky there's right now actually a pretty large osteoporosis and ESRD trial where they're giving bisphosphonates and teriparatide to several hundred ESRD patients. Regarding imaging, and I know that was one of the questions for the case, is it worth imaging these patients? How frequently? So back in 2009, KDIGO, who makes most of our BMD guidelines as nephrologists, basically said it's not worth it because BMD doesn't predict the type of renal osteodystrophy. It doesn't really predict fracture risk. However, multiple studies have come out since then showing that, in fact, low bone density in CKD and in ESRD on a DEXA scan, does predict fractures. We've published this. These are papers by a group in Japan and a group in the US, Yenchek and Imori, showing that, in fact, DEXA scans can predict fractures in CKD and ESRD. So I definitely support regularly measuring BMD, and KDIGO does as well. Now, KDIGO says in patients with CKD 3 to 5 and evidence of the CKD MBD and or risk factors for osteoporosis, they suggest testing. Now, in my mind, every single patient with CKD and has risk factors for fractures and has evidence of a CKD MBD. So it's everyone, but they can qualify it. In my mind, there's no qualifier. Now, when we think about imaging, we're generally thinking about DEXA scans. There are some advanced imaging techniques like HRPQCT. These are largely available as a research tool, but can give you information on bone architecture, maybe even on bone turnover. But there have been studies by several, including Tom Nicholas at Columbia, have shown that this can be used to help improve prediction of fractures in the CKD population. So with that said, hopefully, you're convinced that imaging these patients and at least finding out if they are osteoporotic, have high risk for fracture, is worthwhile. Now, one thing that comes up a lot is how good are bone biomarkers in CKD? And while bone turnover biomarkers are often grossly abnormal in CKD, and the biomarkers can be used to help direct therapy, their performance has not always held up as well as we would like. So when I think about management of osteoporosis and CKD, I generally am thinking about turnover-directed therapy and biomarkers of, and essentially, if you know what kind of turnover the patient has, you can know how to properly manage the patient. And the biomarkers for turnover can help guide that. And in Gina's case, that's really almost all you have to work on, because the patient's not really a candidate for biopsy given their comorbidities, but B, the biomarkers just don't hold up that well. So one of the best papers that looked at how well biomarkers perform and this is in ESRD, but there's similar studies in CKD. And this was by Stuart Sprague, where they looked at 500 Brazilian patients with ESKD and looked at how well various biomarkers predict high versus not high turnover, low versus non-low turnover. You can see you get your best performance if you combine PTH with bone-specific alk-phos, but these AUCs are not great. And so you're going to be wrong a lot. And if you follow the various guidelines, you can see your sensitivity or specificity for low or high turnover in ESRD is pretty poor. This is true in CKD as well. So if you make your decisions entirely based on a biomarker or even a couple biomarkers, you will often be guessing wrong. Now, again, this is looking at single measurements of a biomarker. I do believe looking at trends in biomarkers is extremely useful. And so if you have serial biomarkers and you see something changing, that makes it more interpretable, especially if that biomarker is not renally cleared. So when you think about bone-specific alkaline phosphatase, it's not renally cleared. So if BSAP is rising in response to whatever you've been doing, then their turnover is probably increasing. And if it's decreasing, vice versa. PTH is more tricky that way because PTH is renally cleared, or at least PTH fragments are. So when you see a PTH rising, like in Gina's case, but a GFR declining, it's hard to know, is that reflecting a change in turnover? Is that just reflecting a change in GFR? Then when you add on to the fact that the PTH could be responding to the calcium levels that have changed in response to the bisphosphonate, it makes it really hard to interpret a PTH, especially in isolation in that kind of patient. But on the flip side, if you take a patient whose PTH is high and you start calcitriol and it goes down, you probably slowed down their bone turnover. The question just remains, did you want to slow down their bone turnover? So, the gold standard at getting at turnover and knowing how to manage osteoporosis fractures in the CKD MBD is bone biopsies. And I do them at UCSD. Joe Ix taught me how to do them. And really the indications are quite broad, but if you have a patient with osteoporosis without an obvious cause, and in CKD, that's almost always the case, or fractures with minimal trauma, you can make an argument that you should do a bone biopsy on a patient. Now, I generally, as a rule of thumb, will say it's not worth doing a bone biopsy on a patient who you don't expect to live more than a couple years, because it takes a long time to impact bone health. And so putting a patient through the inconvenience of a bone biopsy and then them starting a therapy a couple months later based on the results, and then to only have them die of cardiovascular disease 6 months later is probably not worth it to the patient. And in the case Gina presented, with somebody with a GFR that's dropped that much with cognitive impairment, weight loss at that age, my suspicion is that patient's life expectancy is less than 2 years. And so a bone biopsy may not be worth it in a patient like that. So a little bit about what a bone biopsy entails. You essentially have the patient take tetracycline for a couple days, twice, 10 or 14 days apart, because it deposits into the bone and you can start getting a dynamic picture of how much bone turnover they have, how much bone formation they had in the time between their tetracycline doses. This is what a sample looks like. This is what the path looks like. And you can see here, this is your unmineralized bone or your osteoid. This is your trabecular bone with osteocytes embedded in it. Here are osteoblasts lining the osteoid that are going to build bone. Here are osteoclasts, which are eating bone away. And this is what the immunofluorescence look like. And depending how much this is kind of your double label picture where you have tetracycline first dose, tetracycline second dose. This can give you a sense of how much bone turnover the patient has, and you get a formal report which tells you about that. The complications of a bone biopsy are rare. They're largely reflect general anesthesia. Bruising isn't uncommon. Infection is extremely rare. There is not normally a lot of postoperative pain. And one thing I want to stress here is I know a lot of people, obviously, very few people are doing these bone biopsies. I think that's really unfortunate. I can tell you, I am extremely not procedurally inclined. I'm a medicine doc through and through. I'm not a surgeon. This is an extremely easy procedure to do, and any orthopedic surgeon or interventional radiologist can do this procedure. They can do it in under 10 minutes. It's probably a half hour of OR time because of the general anesthesia. But if you have a relationship with an orthopedic surgeon or an IR group that's motivated to help these patients, I strongly encourage you to have them read about the procedure. They can reach out to me. I've talked to multiple people in surgery as well as in radiology who have adopted the procedure because of how easy it is. Actually, the hardest part is you just need to get a pathologist, and we send our path to Mayo Clinic to read it. There are lots of groups that do it. It's a simple send out lab, and they can do it for you. And so I think at the end of the day, a lot of your patients will benefit if you can get this kind of thing set up. And it may seem daunting at first, but honestly, for an orthopedic surgeon, this should be incredibly easy if a dumb nephrologist like me is capable of it. So I know that I think really the crux of what I want to focus on is the management of osteoporosis and CKD and how to approach your patients. And when I think about how I manage my osteoporotics and fracturing CKD patients, there's generally these classes of meds that we use. We use vitamin D receptor analogs like calcitriol, calcimimetics. We can use anti-resorptives like bisphosphonates, denosumab. We can use anabolics like Forteo. We can use potentially romosozumab. Notice I didn't really mention 25D like urocalciferol or cholecalciferol. I really don't think there's much role for those medications in patients with CKD because you can't reliably assume they're going to activate vitamin D. They all have a 1-alpha hydroxylase inhibition from FGF23, as well as 1-alpha hydroxylase deficiency because they have loss of nephron mass. So to me, I don't really see a role for it. Why not just give them the active hormone, the calcitriol, and if that's what you're trying to do, if you think they need vitamin D. Kind of a philosophical point here. If as a practitioner, you practice medicine in a way where you say, I'm not going to make decisions or I'm not going to implement therapies that don't have large randomized trials to back up my decision. There's nothing wrong with making that decision. I think that's how most of us were trained, is you need randomized trials to teach you how to practice our fields. And that works great when you're a cardiologist or when you're an oncologist because there are so many large trials. When you're a nephrologist, you don't have that liberty. And when you're a nephrologist managing osteoporosis, you certainly don't have that liberty. Well, everything I show you is going to be based on small studies, small subgroup analyses. There are very few large trials in our field. And so if you want to manage these patients, you're going to have to make your decisions based on things like physiology, understanding how the drugs work, understanding risks and benefits, and making sure your patient understands that you're making a decision that isn't necessarily guided by the FDA stamp of approval or a large trial that was published in New England Journal, but rather just your best guess as to how to manage your patient. Because the alternative is we just continue to let our dialysis patients have hip fractures at 4 times the rate of the general population, and they're often dying from those fractures. So starting with vitamin D receptor agonists, with respect to its effects on bone mineralization, because when you think about what vitamin D does in its most specific effect, it is on mineralization. There are conflicting biopsy studies showing an actual improvement in that. The largest studies on calcitriol have not really shown much benefit. Primo didn't show much benefit for the Primo trial for cardiovascular events, but really we haven't had great data showing improvements in BMD with calcitriol. They are very safe. You really just need to monitor calcium, phosphorus, and PTH. And with some dialysis patients, hyperphosphatemia can become a real problem when you use calcitriol. And KDIGO, and I realize I spelled it KDIGOI, but KDIGO, really at this point, they've kind of softened their stance and have kind of pulled back on the aggressive use of calcitriol. And they basically say you should only use calcitriol on people who require PTH lowering, but they say who needs PTH lowering is somewhat unclear. Probably is only the patients who have rapidly rising or severely elevated PTH levels. They don't really define that in CKD. So, you know, practically speaking, where does that leave us? Well, for any given GFR, a nephrologist should have a sense of where PTH generally hangs out. And if it's really much higher than that, calcitriol makes a lot of sense. But if you're a primary care doctor and you're seeing a CKD3 patient and you're thinking about calcitriol, it's a good thought. I would talk to a nephrologist about it. And the focus of my question to them would be is, do you think this PTH level is uncharacteristic of this degree of CKD? Because it's possible that their PTH needs to be elevated, that they have a PTH resistance, that their PTH is only elevated because they have impaired PTH clearance. So it's not necessarily a bad thing that their PTH might be up a little bit. With respect to calcimimetics like cinacalcet or Sensipar, that's actually a drug we do have a large trial on to kind of direct therapy. And unfortunately, it was negative. So the largest trial of cinacalcet, which again is a calcium sensing receptor agonist, which essentially fools the parathyroid gland into thinking there's calcium around and suppresses PTH that way. 3,883 patients in the EVOLVE trial who were on dialysis were followed for 4 years. Now, unfortunately, EVOLVE was powered for a cardiovascular endpoint, and it was a negative study. Fractures were a secondary endpoint and was a little underpowered for fractures, and it was unfortunately a negative study for fractures as well. However, when they looked at subgroup analyses of patients over the age of 65 or in patients who've had fractures in the past, you can see here that fractures were much higher in the placebo group than in the Sensipar group. So there is some signal that there is efficacy, and it's important to realize that in EVOLVE, they basically gave anybody who had quote unquote hyperparathyroidism Sensipar or cinacalcet, but realize that the definition of hyperparathyroidism in ESRD is kind of ambiguous. And so it's possible that if they were able to truly target high bone turnover, that there would have been a better signal seen. But because it's hard to differentiate it from low turnover, because the biomarkers aren't that reliable, you may have lost your benefits, because if you're giving somebody low turnover with low turnover Sensipar, there's no really reason it should help. Things to monitor for when you use these drugs are really GI toxicity and hypocalcemia. Nausea is really common. And a lot of your patients with hyperpara who have really high PTHs, it's going to be driven in part by hyperphosphatemia. They're going to be on phosphate binders. Those also cause GI toxicity. So most of the time, these drugs get limited because I can't go up on the dose as high as I want because of GI effects. But moving on to bisphosphonates. So obviously this is one of the best studied drugs we have in osteoporosis. And unfortunately, most of the large clinical trials specifically avoid advanced CKD and ESKD patients. And so most of the data that we have in CKD is really from subgroup analyses of the phase 3 trials. And then you end up getting mostly CKD3, you don't really get a lot of CKD4, certainly not any dialysis patients. There is evidence of efficacy, and here this is a study in more advanced CKD, where you can see there were 6,500 people. Most of them didn't fall into the severely reduced group, but you can see that there were benefits seen at the hip in BMD in this one study. By Jamal and colleagues. At the femoral neck and spine, BMD did not really improve and fractures did not decline. But again, the study was powered for changes in BMD, not necessarily for fractures. So there was a signal here that at multiple levels of CKD, bisphosphonates can help at least in hip BMD. Here's a study in dialysis where they showed these are 2 different doses of bisphosphonate, and BMD improved amongst the dialysis patients treated with a bisphosphonate But unfortunately, this is a study of 13 patients, and that's how it generally goes when you look at the more advanced CKD and dialysis is these trials are really small, and so you can only take so much from them. With respect to safety, obviously I think the thing we most worry about are bisphosphonates are associated with kidney disease and EGFR decline. Now, with certain bisphosphonates, you can actually see FSGS, which is a proteinuric kidney disease. With most of them, you just see this potential steady decline in EGFR. There have been several studies looking at this, how bad is this, and what % of patients are going to actually experience this, and it's probably something in the order of 10%, maybe 15%. So most of the time, it should not occur, especially if you use low doses, but it is a risk. And getting back to Gina's case, where she had a patient who's already declining, in a patient who's already declining, whether they're on a bisphosphonate or not, it's very hard to give them a bisphosphonate, because if they've been declining, they will probably continue to decline. You won't know if it's the bisphosphonate or not. So it's very hard to start it. Even if their GFR is 55, if their GFR was 75 and is now down to 55, it's not really a good idea to start a bisphosphonate, because if the next GFR is 45, you're not going to know, is that just the same kidney disease that's been ongoing, or is my drug doing it? But if you have a patient who has a stable GFR, I do think it's reasonable to try a bisphosphonate, and I'll even go so far as if their GFR is in the high 20s, but it's been stable, I think it's reasonable to start it and just stop it if they develop EGFR decline. The other thing that we worry a lot about is adynamic bone disease. And certainly bisphosphonates are going to lower turnover. And if you have a patient with high bone turnover, I think these are really important drugs to use. The incidence of aerodynamic bone after giving bisphosphonates, there are conflicting studies. The study on the left here, you can see the incidence of low turnover didn't really change after getting zoledronic acid. But there's another study here as a transplant study by, I think, Maria Coca's group, where all the patients that got a pamidronate developed adynamic bone after a few years. So it's not clear how much risk there is in causing adynamic bone, but I'd say the goal of treating high bone turnover osteoporosis or osteodystrophy is to slow down turnover. And sometimes you need to be aggressive. And if you find out that your patient develops adynamic bone, we can treat that too. We can give anabolics. So my feeling is these drugs do have a role, with the knowledge that you're going to have to monitor their EGFR. You're going to have to monitor some biomarkers, and not just PTH, because PTH may just go up in response to the bisphosphonate, but perhaps using a drug like or monitoring bone-specific alk-phos. Moving on to denosumab and Rank-Ligand inhibitors, there is evidence of improvements in BMD, even in advanced CKD, with the Rank-Ligand inhibitors. I think they definitely have a role, and they are not nephrotoxic. That's the key. They're not nephrotoxic. The other thing to note is hypocalcemia is a real side effect, and it can be quite severe. So what that means is when I have a CKD patient or even an advanced CKD patient who I am considering these drugs for, I get their calcium up close to 11 before I even start with calcitriol, which will also slow down their bone turnover. And then I check their PTH their calcium at least weekly after starting, sometimes even twice a week. If it's a dialysis patient, you can check it 3 times a week because they're at dialysis anyway. And just be aggressive and on top of their calcium, and you should be able to prevent significant hypocalcemic events. The issue also is you get rebound osteoclast activity, and we'll have to potentially cap it with a bisphosphonate, which is why I think these drugs are really good for your advanced CKD patients who are going to be on dialysis soon anyway, because then you can give them the bisphosphonate on dialysis and you don't have to worry about the EGFR decline quite as much because they're already on dialysis anyway. I think hormonal therapies are dramatically underutilized in advanced CKD. There aren't great studies. There are only small studies showing improvements in BMD with raloxifene, but there is a clear evidence of efficacy in the general population. And if you have high turnover, they inhibit osteoclast activity. This figure here I'm showing the p-value was actually significant, despite these graphs looking quite similar, that raloxifene improved bone density in 60 dialysis patients at the lumbar spine. So obviously you're going to use these in women, but that's where the larger burden of osteoporosis exists. There is a theoretical risk of VTE, but these probably are extremely minimal with SERMs as opposed to an estrogen therapy. Moving on to the anabolics, because I know we're short on time. There is evidence of efficacy in CKD of improvements in BMD at the hip using teriparatide. Abaloparatide is a little less studied. Again, the trials in dialysis are extremely small, but fortunately, these drugs do not affect kidney function. So if you have low turnover, I think whether you have biomarker evidence that's somehow reliable or bone biopsy evidence, which would be preferable of low turnover. And again, about 30% of your advanced CKD dialysis are going to have low turnover, maybe a little less in your earlier CKD, but it's still quite common. You know, you're not going to want to, you know, if you inhibit somebody, if you inhibit osteoclasts in somebody who doesn't really have osteoclasts because they have low turnover, it's not really going to help. So these drugs have an important role. They do cause hypercalcemia. You often will want to stop their calcitriol while they're on it. And in Gina's case, as we'll get to in a second, that might be the way we need to go. Lastly, there's a drug called romosozumab that I'm sure you're familiar with, or Evenity, which is a sclerostin antibody. It has mixed anabolic and anti-resorptive properties. Its efficacy in ESRD and advanced CKD has not really been evaluated. There are very small safety studies to date. They've been well tolerated in safety studies, but there is a black box CVD warning on it. And while that warning is generated by very few cardiovascular events in the trials, that is the #1 cause of death in advanced CKD and ESRD. So at this point, I'm not yet prescribing this in that population because I worry so much about CVD. I'm not going to go through this whole table, but you can find this in our paper. This is some dosing options that you have when you're treating patients with advanced CKD or even early CKD. If you're worried about their renal function, this is what they've used in the trials in these patients. And this is, so generally speaking, we have a treatment algorithm in the paper, but if you have a patient with high turnover, they should be treated with vitamin D receptor agonists, calcimimetics, and potentially anti-resorptives like bisphosphonates or denosumab. If you have low turnover, you probably should be on an anabolic. And if you have evidence of osteomalacia, which you're probably only going to know on a bone biopsy, they should get a vitamin D receptor agonist. This algorithm kind of breaks down how we approach the management. This is in dialysis specifically, but you can kind of use it a little bit as a guide to earlier stages of CKD. I'm not going to walk through it because I know we're short on time. And if someone has questions afterwards, I'm happy to walk through it. I just want to thank my mentors, Joe Wicks and Isidro Solewski, who mentored me on bone biopsies and our mentors on my K. Deb Cotto, who was the UCSD site PI or the San Diego site PI for Mr. Ross, who handed that to me, and I'm now site PI on Mr. Ross, and she's been a tremendous mentor to me as well, and a tremendous loss to us here at San Diego. Here are some of my references. This is me and Rocky, my dog.